So let's look at where these show up on the EKG wave here. So we're at the SA node, which is our pacemaker cell, sinoatrial. The right atrium is filled with blood. Electrical signal for each heart is going to begin here. All right, and so what we see is the P wave. This occurs with the contraction of the atria. So when your heart's atrium is full of that blood, the electrical signal will spread across the cells of your heart in the right and left atria, all right, causing that contraction or squeezing. And on these diagrams here, you can see these as these little dots showing that's where we're at in this diagram. So this is what occurs with the P wave, is the contraction of the atria. We do sometimes refer to this as the PQ segment, so it's the segment going from P to Q, all right, and so the AV node, remember the AV is the gatekeeper, so it slows just a little bit at this spot, which allows the ventricles to fill with blood. So that's what is occurring during the PQ segment, all right. So we can break it down to P, then what happens between PQ, and now at the Q wave, the electrical signal is going to be moving at the Q portion on the wave, I should say, down into the bundle of His and to the right and left bundle branches. You can see there is Q here, and you can see there is something really exciting about to occur there with that jump up in the slot where you're going to have a significant event. All right, so now we're looking at the R segment. We've had that rapid depolarization, this increase in the line here, all right, that is represented by the R wave. So going from Q to R. The electrical signal is going to travel through ththose Purkinje fibers, the little spider web-like fibers, to the individual cells, and causing them to contract all together simultaneously. This is going to be the contraction of the left ventricle, is what's represented by the R wave. So then the S portion going from R to S is going to be contraction of the right ventricle. And then the T wave here, there's R to S, and then we have T wave here is going to be that diastole, the relaxation of the ventricles. So here you can see we've got two full cycles here that are occurring in one segment here in 1 second. You can see we have our P wave, and then from this section to this section is the PR interval, and then from here to here is the QT interval. Then we have our QRS wave, as it is often referred to, and the T wave. And again, you can also break that down into individual segments from P to R and from S to T, and the QRS complex is down here. So what is the purpose of an EKG? Well, of course, this is to record that electrical signal of the heart and use it for diagnostics to see where there might be a potential problem occurring. We will have careful placement of surface electrodes. We'll put them on the body in particular places, and those can even vary when you're looking for something different. It's possible for us then, as we place these, to record that complex compound electrical signal of the heart and get that EKG wave. We call this an electrocardiogram, which can also be abbreviated ECG, but is commonly abbreviated as EKG. Some of the reasons that this might be run are things like if they think you're having a heart attack, pulmonary embolism, fainting spells, even things like seizures. Electrolyte imbalances can absolutely cause these. Things like hyperkalemia or elevated potassium levels can really affect your heart rate, even different medications. So this is just kind of showing you the general placement of EKG electrodes for getting that EKG done. Of course, this is not training for that, but I just thought it would be of interest to some of you. If you work in a doctor's office that does this type of work, like a cardiologist, you may actually get to do this, but you would have some training for that. So to review, in an ECG or electrocardiogram or EKG, the P wave is caused by that depolarization of atrial muscle fibers. So atrial depolarization. The PQ interval tells us how long it takes for the cardiac impulse to travel from the SA node to the AV node. QRS complex is going to show us the ventricular depolarization, and T wave is the ventricular repolarization. And again, we use this in order to assess the heart's function in wave conduction, or I'm sorry, in electrical current conduction. So what are some ways that we regulate the cardiac cycle? Well, the SA node, we already know, controls the heart rate. There's also some sympathetic and parasympathetic nervous system involvement that can affect the heart rate as well. We have several regulatory reflex centers. We can have some other factors that can affect your heart rate, like exercise. We already know that elevates your heart rate. Body temperature. Have you ever experienced when you get really hot, your heart tends to beat faster? If you run or jog outside in the summer, that is definitely something, or do any kind of exercise outside in the summer, that is definitely something you'll notice, that heart rate is elevated much quicker when you're hot. If you're cold, I would assume that it's going to elevate slower, right? And so also concentration of ions, and this is really important for that electrolyte balance. Potassium specifically, and calcium. Potassium is a biggie. Parasympathetic impulses affect us via going through the vagus nerve, and they can decrease heart action. Remember, sympathetic and parasympathetic is that fight or flight response. So some of them are going to increase the action to get you ready to fight, as in the sympathetic, or decrease it in order to relax, rest and relax, right? And so the cardiac center is what is going to regulate those autonomic impulses going directly to the heart. The volume of blood that is pumped is going to change to accommodate our needs. So that's part of the reason we need to be able to do this with parasympathetic and sympathetic. So an increase might be needed for exercise. The heart rate is going to increase. You're bringing more oxygen to your muscles. Some other factors, of course, like we said, calcium, potassium, and those particular ions. Potassium affects the electrical potential of the cell membrane, and it changes the threshold needed to trigger an action potential. Too much calcium is what we call hyperkalemia. That is going to decrease the rate and force of contraction or block conduction, and your heart can actually stop. So this is really important. If it is too low, you have hypo meaning low, kalemia, and the heart may develop arrhythmia, which is an abnormal rhythm. All right. Too much calcium can cause hyper or above calcemia, hypercalcemia, which increases your heart action, which can cause extended or longer heart contractions. Too low calcium, hypocalcemia, can depress heart action. So it would do the opposite. So it would decrease those contractions. Acetylcholine is a neurotransmitter that can also decrease the SA and AV node activity, which suppresses heart rate. Parasympathetic can actually change the activity in both directions, okay? Norepinephrine as well. It's going to increase the rate and force of contraction. This is just an overview of the baroreceptor reflex control for blood pressure. This comes from the cardiac control center in the medulla oblongata and helps regulate the inhibitory and excitatory effects. So you can see we have baroreceptors. Baroreceptors modulate or receive information, I should say, about blood pressure. They're in the carotid arteries in the carotid sinus area, and they're going to transmit signals to the medulla oblongata on up to the hypothalamus and the cerebrum in order to be interpreted. And then information is going to be relayed back through parasympathetic fibers in the vagus nerve to alter the heart rate. These I put here mostly for interest, just to see what the effects on an EKG are with an arrhythmia. All right, so for ventricular fibrillation, that's a rapid, uncontrolled depolarization of ventricles. This is the most life-threatening occurrence here. The blood is not being pumped. Atrial fibrillation is not life-threatening. because blood is still pumping. So VFib is life-threatening, AFib not so much. To the right here, we have tachycardia, and that is a blood, not a blood pressure, but a heart rate above 100. This rapid heart rate can be due to things like exercise, high body temperature, drugs, heart disease, even anemia. Below that, we have bradycardia, meaning slow. So tachy is fast, bradycardia is slow, and you can see the distance between each of these waves and how different that is. Bradycardia is a heartbeat lower than 60 beats per minute, and this can be caused by low body temperature, drugs. It can also be low during sleep normally. Athletes have a lower resting heart rate because their heart is so efficient. On the bottom left here, we have atrial flutter, which is regular but very rapid heartbeat, between 250 and 350 times per minute. It can occasionally happen to people with a normal heart, but frequently if it's frequent, it can cause damage to the myocardium or the heart muscle cells themselves. We can have what we call an ectopic heart rate, which is just a premature, an extra heartbeat, or you can have a premature heartbeat. The cardiac impulse can actually sometimes also arise from other places than the SA node, so that would be a cardiac conduction issue. It can come from ischemic tissues, irritated muscle fibers, but any interference or block in that cardiac impulse can cause some type of arrhythmia. So remember, the cardiovascular system is a closed circuit, and that just means that it's complete connection from blood to flow all the way from one end to the other end. Arteries carry oxygenated blood away from the heart to the tissues, with one exception. That is the pulmonary arteries, which carry blood to the lungs to be oxygenated. So blood vessels, those are the organs of our cardiovascular system, and they include arteries, arterioles, capillaries, veins, and venules. And veins carry blood towards the atria of the heart and have the greatest, or contain the greatest volume of blood. Here we're going to look at the difference between the structure of an artery and a vein. And remember, structure determines function, so there is a reason why these structures are different. So these are blood vessels. We have an artery on the left and a vein on the right, and it's cut away so you can actually see the walls, all right? So even on a smaller scale, structure determines function. These have slightly different functions, right? So the lumen is going to be larger in the vein than in the artery. Veins contain valves. You can see the valve there, and the artery does not. Veins are generally larger in diameter and, as I already said, carry more blood volume. They also have thinner walls. Look at the difference in the size of these walls. This is pretty thin here, and this is pretty thick here. All right, so arteries are smaller, have thicker walls, and carry blood under high pressure. So if you have a lot of pressure, you're going to need to have thicker walls. They have that higher pressure because they need to get blood out to all the areas of the body. So you got to pump harder in order to get there. So to withstand that, they have the thicker walls. When blood reaches the veins, it comes from tiny capillaries. So blood pressure decreases while flowing into them. So what is the difference between an artery and an arteriole? Arteries are strong. They're adapted for carrying blood away under that high pressure. Then they subdivide and get into smaller, thinner tubes, and that's when we call an arteriole. So an arteriole is smaller than an artery. These guys have 3 layers, and we call them tunics, and they're made of endothelium with some connective tissue surrounding them. This is going to provide a smooth surface for blood cells and platelets to flow. Endothelial lining is going to secrete some substances that inhibit platelet aggregation. In other words, platelets sticking together or clumping together, and that's going to help prevent those blood clots. Also other substances that dilate and constrict blood vessels. And so this helps regulate blood flow. Both arteries and arterioles can undergo vasoconstriction, which means getting smaller, being constricted, and dilation, which means opening it up to allow an increase in flow. Changes in the diameter of arteries and arterioles greatly influence blood flow and blood pressure, all right? So arteries carry that blood under really, really high pressure. Arterioles, the pressure is going to be lower, but they still help control blood flow, all right? Capillaries are the smallest. These have the tiniest, smallest diameter blood vessels, and they connect the arteriole to the smallest venule, which is basically the smallest portion of a vein. And so they're extensions of the inner lining of arterioles. They're made of endothelium only, and they are semi-permeable, which allows exchange to occur of substances between blood and tissues. So that's very important. And you can see these capillaries here. They're highlighted in purple because this is where the exchange of oxygen and carbon dioxide occur. So this is where we change over from oxygenated to deoxygenated blood and vice versa. So here we have a capillary network, and you can see those capillaries as they join the arterioles and the venules together. This is an arrangement of a capillary network, or the arrangement of a capillary network depends on the cellular requirement for each specific tissue. So basically what the tissue needs determines the structure. Structure determines function. You can say it vice versa as well. Function determines structure. So blood flow can also vary depending on the type of tissue and the requirements of oxygen and nutrients that are needed. So how do substances travel in and out of our vessels? Water and dissolved substances are going to leave the arterial end of a capillary due to what we call hydrostatic pressure. Hydrostatic pressure, which is written right here for you, hydrostatic pressure. That is going to be due to a net outward pressure being higher outside, okay, than the osmotic pressure inside. So we're going along a pressure gradient. It is then going to enter the venule end of a capillary due to a net inward osmotic pressure being higher than hydrostatic pressure. Substances are going to move in and out, of course, along their concentration gradients. And so you can see there are some different numbers on here. Blood flowing in from the arteriole over here with an outside, having that outward force causing the hydrostatic pressure causing it to flow out. Inward force of osmotic pressure pulling things in. Here we're looking at the difference between venules and veins. Venules are microscopic. These are just like capillaries, but they are on the vein side. These are tiny. So they continue from the capillaries and merge to form veins. They basically just get larger. They have thinner walls than arterioles and less smooth muscle and elastic tissue. Veins are going to be larger, but they are thinner. They have thinner walls, as we looked at, than arteries. The middle wall is not near as developed. Remember, they have flap-like valves and carry blood under much lower pressure than arteries. And these can actually function as a reservoir for blood. They can hold blood for us. When smooth muscles in the walls of the arteries are stimulated to contract during as blood pressure increases, veins are carrying deoxygenated blood back to the atria. And they're following pathways parallel basically to the arteries. And you'll see that in lab. Veins have got those 3 layers of tissue, middle wall not as developed. They have those semilunar valves, all right? And they are open as long as blood flow is towards the heart, and they prevent backflow from occurring. So that's very important.